All right, next we're going to hear from Dr. Vivianne Tawfik, MD, PhD, and Assistant Professor in the Department of Anesthesiology, Perioperative, and Pain Medicine at Stanford. Dr. Tawfik received her bachelor's from McGill University in Montreal, Canada, and then earned her MD and PhD in neuroscience from Dartmouth. After a year of surgical internship there, she moved to California and pursued a residency training in anesthesiology as part of the Fellowship in Anesthesia Research and Medicine, or FARM program, of which she now serves as director. After completion of her subspecialty fellowship training in pain medicine, Dr. Tawfik joined the faculty at Stanford and continues to research the immune contribution to persistent pain while treating patients suffering from chronic pain. Notably, she specializes in the treatment of complex chronic pain disorders, including chronic postoperative pain, complex regional pain syndrome, and peripheral nerve injury. In addition to pursuing exciting scientific questions in a clinically informed way, Dr. Tawfik enjoys mentoring students and other trainees. We look forward to her talk, Neuroimmune Interactions in Chronic Pain, from clinical to clinically informed basic science. Welcome, Dr. Tawfik.
Thanks, Stephanie, for the invitation, and I assume you can hear me and see my slides. Okay, great. Well, thank you so much for staying for the last hour, and obviously very hard acts to follow with the prior two talks, but hopefully I have a slightly different perspective to offer, sort of moving from my clinical work to the basic science work that we've been doing in my lab for the past few years. So I don't have any disclosures, but I will discuss off-label use of drugs. So of course, everybody here is interested in pain, so I don't need to tell you that it's a major clinical problem affecting about 100 million Americans at a huge cost to society. But one thing that really struck me when I moved from my PhD back to my clinical training and ultimately did my subspecialty in pain medicine was really how many patients were affected by it in unique ways, and how we really didn't have a whole lot of mechanism-based treatment for individual patients. Some days it almost seemed like, you know, every Monday, everybody got gabapentin, and on Tuesdays, everybody got a tricyclic antidepressant. But we weren't really able to offer patients a specific treatment that matched the mechanism of their pain, whereas the different types of pain they presented with may have very specific or very different causes. So one thing I think a lot about, and I'm sure this group does as well, given the name of the group, is when is acute pain no longer acute pain? And it's something I think about a lot because it's normal, as we all know, to have acute pain, and it's important to have acute pain for survival. But when acute pain becomes chronic, that is when it's something that needs to trigger more active treatment. And so one thing I like to speak with the surgeons here and at other institutions about is about trajectory, because in general, patients, people should be improving, not worsening, in the weeks after an injury or a surgery or a trauma. And for those of us who are anesthesiologists and working in the operating room, we are there in the operating room when the surgery is happening, when the trauma is being dealt with. And this provides a sort of a glimpse into the trajectory and a glimpse into when acute pain gets initiated. And so in particular, as an anesthesiologist, I've been interested in the concept, excuse me, of chronic post-surgical pain, which is really defined as pain that lasts greater than 3 months after surgery, localized to a surgical site or to a referred area. Of course, other possible causes have to be excluded, such as infection. And it's different in character from what presented. So if a patient comes in with knee pain and they continue to have the exact same knee pain after surgery, we wouldn't necessarily consider that chronic post-surgical pain, but something may be different about the character of their pain. Maybe now it feels more numb or more tingling with paresthesias, for example. And as Dr. Sluka mentioned in her introduction to the group, it's quite highly prevalent, from 5 to 35% of patients, depending on the surgery type. In particular, it's very highly prevalent after orthopedic procedures, which is relevant because these are procedures that are done very often in this country every day. And so if we look just at total hip arthroplasty, in one systematic review, there were estimated to be between 10 and 20% of patients with long-term pain after total hip. After total knee, a higher percentage, up to 35% of patients with long-term pain. And then around that that percentage as well is distal radius fracture, which is an extremely common type of injury, which is literally just falling on an outstretched arm and having a wrist fracture. And this is estimated to cause long-term pain in about 30% of patients at 1 year post-injury or post-fracture. So this is not a small problem that we're talking about. But again, as I said prior, each patient who comes in with pain has it for a different reason. And this is just an example of a patient of mine, and you can see here a picture of her feet, and clearly the right foot looks different than the left. And not all chronic post-injury pain is the same, and not each individual's pain is the same. And so we really do need to some degree to consider the actual mechanism of the person who's presenting in front of us for treatment. And so this patient of mine is a 28-year-old female who came in with a twisted ankle and complained of persistent pain, swelling, redness, and warmth of her right foot, which you can see very clearly in the photo. And this was a group of patients that over my time in the clinic, I seemed to sort of accumulate this type of patient, these young women who are showing up with what would be an otherwise sort of benign injury or a benign surgery, but yet we're having pretty profound symptoms. And ultimately, this patient and many others who I care for are patients who are diagnosed with something called complex regional pain syndrome, which is really a form of chronic pain that occurs in the limbs. So I usually think about it as hands and feet, and often results from minor trauma or surgery. And this is a type of chronic pain that has pretty characteristic features, although if we have time to talk about it, I think is quite diverse in its presentation, even with that. But we have these criteria that were developed about 10 years ago now, where we diagnose patients based on their presentation of symptoms and signs in these 4 categories. So sensory symptoms, I think, we all know if a patient comes to the pain medicine clinic, they tend to have pain. So that's sort of a given. But one thing that's particularly interesting about these patients is they have the classic allodynia, which is something we test in mice, and they have that sort of classic touch sensitivity, and they might change the clothes they wear. I have many patients with CRPS who will only wear tank tops so that the cloth of a shirt doesn't touch their arms, or they might wear flip-flops rather than closed-toe shoes because the feeling of the shoe on their foot is very uncomfortable. They also have pseudomotor symptoms, including edema, sweating, and hair or nail growth changes, vasomotor symptoms, such as differences in temperature or color, one side to the other, and you can see that quite clearly in the image from the prior slide, as well as motor changes, where there's loss of range of motion, there might be tremor of the injured limb, and weakness. So it's a pretty profound condition when it's diagnosed. And the interesting thing about CRPS is that it's thought to consist of 2 phases. And it really goes from this more acute or peripheral phase to a more chronic or central phase. And I think in a way, even though in this talk, I'm sort of focusing on this, albeit rare condition of complex regional pain syndrome, I think it may serve as an example of the acute to chronic pain transition that's actually quite fascinating. And the reason I say that is because during the acute phase, it's really a peripheral condition. You can see a red, hot, swollen limb. If you take a biopsy at the skin, there'll be elevated skin cytokines. And this stage is more responsive to treatment. And so that's pretty useful if you catch people early. But over time, patients transition to the chronic or more central phase. The limb may become cool and atrophic. And if you take CSF through a lumbar puncture now, you can see elevated cytokines in the CSF and no longer any elevated cytokines in the skin. So it seems to transition, as I said, from this more acute peripheral phase to this more chronic or central phase. I'm saying this as if it's sort of very clear, and it's really not. And I have patients who may, sort of flip-flop between being red hot and cold and atrophic, even within a few days or weeks. But in general, if you take all comers and sort of look at their symptoms, those who have this more cool atrophic limb tend to have had CRPS for longer. So all of this sounds maybe reasonable, that if you have an injury, you should be red hot and swollen. And many of us have twisted our ankles or had a small fracture and ended up with inflammation, which is normal because we know that that's part of the healing response. And we need to have inflammation in order to promote recovery of muscles and bones and nerves that are injured. The problem with CRPS is I like to say that it's really sort of exuberant peripheral inflammation where the trajectory is different. Again, coming back to this, patients should be improving and not worsening in the weeks after their injury, their surgery, or their trauma. So when speaking with, a patient or their surgeon, I might say, well, you've done 1,000 carpal tunnel releases. And at the 6-week follow-up, all of your patients are back to activities of daily living. They're back to gardening. They're back to doing what they enjoy. But, you see a few patients who are still complaining of pain, who are still complaining of swelling. Those are the patients who I want to see. Those are the patients we need to sort of have a sort of quick triggered response to at least follow more closely and engage with at that early stage, rather than waiting a year and saying, oh, yeah, we should have maybe, done something earlier. So the trajectory is really important. As I said, CRPS is not that common. It only occurs in about 5 to 25 cases per 100,000 per year, about 50,000 cases every year. Of course, because my clinical practice is almost entirely focused on CRPS and chronic post-surgical pain, it seems to me to be much more prevalent than that. But I think it's also probably under-recognized and underdiagnosed. Again, because it sort of looks like what we expect, at least in the short term, after an injury or surgery. Important for this group, I think, are the risk factors for the development of CRPS. As I've already suggested, the female prevalence is higher, about 3 to 1 female to male. Of course, they most of the time have a history of a trauma or a surgery. There are some genetic factors, although they have yet to be truly worked out. And then there is this concept that will be relevant when I sort of transition to speaking about the basic science side of what we do. But this idea of cast tightness or immobility after injury that can lead to a higher risk. And it's about a 5-fold increased risk of CRPS developing if patients report a subjective sense of the cast being too tight. And while this seems maybe sort of like a confusing situation, is that maybe somebody actually casted the patient too tightly and therefore, all they should have done was just cast it more loosely? Or is it that the person placing the cast does the same thing every time and the patient had more swelling than expected? And so it's hard to know in that case what it is. But in the end, if somebody complains of cast tightness, I think it's really important to take that seriously and change the cast. And I've definitely heard this story more than a dozen times where patients will come in and say, well, and then they placed the cast and it was too tight and it hurt. And when they took it off, my hand was quite swollen or my foot was quite swollen. So it definitely seems to be a risk factor. That immobility seems to be a risk factor. So the mechanisms underlying this particular condition are pretty diverse. And this is a nice schematic made in BioRender by one of my undergraduate students, Claire Jordan. And you can see, there's certainly peripheral inflammation that's important. And I have here sort of my favorite peripheral immune cells, macrophages, neutrophils. And then there's also a sympathetic component of CRPS, which I don't have time to talk about it today, but one form of CRPS was previously called reflex sympathetic dystrophy because of the thought that there was a aberrant response of the sympathetic nervous system in cases of these peripheral injuries. Most interesting to us has been this role of neuroimmune cells in the spinal cord, both microglia and astrocytes, at mediating responses between the primary afferent neurons and the postsynaptic neurons in the dorsal horn of the spinal cord. And I'll just mention briefly here that the cortical representation in patients with CRPS has actually been shown to be changed. And this is really interesting because many of these patients develop almost a stroke-like hemi-neglect after injury, where they will start to do everything with their uninjured limb and completely ignore the injured limb, which is maybe a survival response. You can think about it in that way. So there's a lot of research that's focused on sort of retraining in terms of cortical representation. So overall, there's many different factors involved, but we're particularly involved in the neuroimmune components of CRPS. And again, as an example of a condition in which there does seem to be a clear acute to chronic transition. But these patients don't have a lot of treatment options, and our treatment of them in our clinic is quite multidisciplinary, involving really a biopsychosocial model involving our pain psychologists, physical therapists, occupational therapists, and medication management, as well as interventional treatments. But overall, they really do have few treatment options, especially when they're in that more chronic phase. And so just as an example of, how we've sort of thought about the treatment of these patients from an immune modulation perspective, we have shown and others have shown that there are definitely immune mechanisms contributing to CRPS.